Ma'am,
Yeah.
still extend.
Yeah, that is fine. Leave it there. So now let me come back to the metabolic component of the acid base. This is important because maybe I should put these slides because I like to tell you a little bit about a scenario and then go for that. So whenever you have got metabolic acidosis, what will you do? You have ventilate. I told you in the beginning itself, the PCO2 may be up to limit of compensation may be up to 12. Now, if you do metabolic alkalosis, what will happen? The alveolar hypoventilation, the PCO2 will go up, which can go up to 50 or 55 just to for the metabolic alkalosis. Suppose somebody is having low potassium, low magnesium, been in some nursing home and not eating properly. So if they come with a severe metabolic alkalosis, the alveolar hypoventilation will compensate. PCO2 can go up high and they can become a little drowsy. So not looking at all these things, if you just start your therapy, maybe not a good idea. Next slide. So these are the normal anions and the cations, you all know it. So these are the almost, both of them will be almost normally same. Sodium, potassium, magnesium, calcium, and proteins, organic acids, phosphates, bicarb. Bicarb is the main thing, and chloride. Bicarb and the chloride are the main anions in our body. The rest of it is also important, but these are the anions and cations. Next slide, please. So these are the unmeasured anions, the proteins, organic acids, phosphate and sulfate. So usually they form about 23 milliequivalents. Unmeasured cations of calcium, of course, potassium, magnesium also we don't really measure. Even sodium is measured, potassium is also measured. Nowadays, if you measure potassium, you also have to measure magnesium. So these are about these are the cations. Okay, these are cations and anions are almost similar to the composition to each other. Next slide. So I was telling you that there are two more formula which are important for the metabolic disturbance. So the respiratory system will quickly respond to any metabolic disturbance. And if you want to have, usually you have this formula called the Winter's formula. You all know that. So in that we calculate the expected PaCO2. So if you have got metabolic acidosis, you want to know what is the PCO2, where's it gone up, gone down or not, and sufficiently gone down. So for that, you have to use 1.5 multiplied by bicarb plus 8 plus 2. So that is the Winter's formula. And if it is metabolic alkalosis, 0.7 multiplied by bicarb plus 21. So these are the two for metabolic acidosis and alkalosis. And I told you 4 formula for respiratory acidosis, acute chronic, and respiratory alkalosis, acute chronic. So these are the 6 formula which you have to learn in order to read correctly your ABG. Okay, so that is a must. Whether you just 2 or 3 times, once you do that, it just sits in your head. Okay, next. Yeah. So now, whenever you diagnose, if it is it respiratory acidosis, then you're diagnosed thinking that PCO2 is high and the pH is low. So we diagnose, we are thinking that it is respiratory acidosis. Then we say, what is the compensation? If it is acute, compensation up to about 12 or 15, you will be, up to 30, you will be compensating. And if it is chronic, you will take that one. So first of all, when these are going, you have to know the compensation. If the compensation is higher, or if the compensation is lower, then you may have to think that there could be some other thing. Maybe there is a mixed acidosis or mixed alkalosis or some other things. So normally you will not be having respiratory acidosis, respiratory alkalosis. But also to find out other things, from there you will know. And net gap, expected compensation. These are the main things which you have to look at. Okay, ABG in class, you will not get it, but today if you go back, read a little bit more, then you will understand it better. Okay, next. So these are the mixed acid-base disorder. You can have metabolic acidosis, respiratory acidosis. You can have metabolic acidosis and respiratory alkalosis. You can have metabolic alkalosis and respiratory alkalosis. You can have metabolic alkalosis and respiratory acidosis. So normally what you don't have is respiratory acidosis and respiratory alkalosis. You don't have it together. So that is what you have to understand, that where is the compensation is not up to the mark, then you have to think whether there is anything else. Okay, next slide, please. So other things which you all have to know is your anion gap. So what are the anions? We have already talked sodium, the anion, which usually takes sodium, potassium, but normally sodium minus chloride and bicarb. These are anions, the main anions. The normal anion gap is around 10 to 12. So if the anion gap is more than 12, we have to look at what is causing this acidosis. Okay, whether it is lactic acidosis, whether it is ketoacidosis. Like you see people who will come for with a lot of shock, in which lactate is very high. So that can cause acidosis, right? When there is hypoxia at the cellular level. So lactate is more rather than the ATP which should be generated. Here you are having lactic acidosis. Suppose you have got, even in diabetics, you have got ketone. So ketoacidosis. So these are all the things which you can have. So whenever the anion gap is more than 12 or 15, you should think there is other than this, there is something else. Next slide. So what is anion gap? I told you. Then what is the other one is an osmolar gap. Normally what do? What is the normal osmolarity? You know, of this thing about 300, something like that. Okay. When you have plasma osmolarity, usually we calculate 2 into sodium plus glucose by 18 plus B1 by 20. So this is usually calculated, should agree within about 10 to 15 millimoles per. So this measures the unmeasured non-ionized compounds. So suppose if the osmolar gap means you calculate and also send it to the lab, if there is a lot of difference, then you can think about that there is something is not right. But normally they also sometimes calculate. So really many times we don't send, but occasionally we do send it to the osmolar gap. For calculating the osmolar gap, we send the osmolarity. Okay, next. So there is another thing called the urine anion gap, where it is sodium, potassium minus this chloride. So if the urine anion gap is negative, there's high urinary ammonia excretion. If it's positive, low urinary. What does it really tell you is whether it is the acidosis is due to urinary problem or the kidney or not. So that is how it is usually diagnosed. Next. So what are we going to do? Is it acidosis? So if it is acidosis, pH is low. So you said it is acidosis. So is it metabolic? If you think it is metabolic, then what you should look at? You should look at bicarb. If the pH is low, the bicarb also will be low. So then you say, okay, this looks like metabolic acidosis. Then you calculate with the metabolic acidosis, is it compensated with the, your bicarb and your metabolic acidosis? How much is your PaCO2? Is it low? How much is it low? Is it within the limits of compensation, high or low? Then you can say, but is it a high anion gap or non-gap acidosis? Is it a hyperchloremic metabolic acidosis? If it is a very high anion gap acidosis, then it's a pure anion gap or a mixed metabolic disorder. Then there's another one called the delta anion gap. Okay, the change in the bicarb to change in the anion gap. So these two things we put together and calculate delta by delta is equal to 1:1. If it is less than 1, then it is a mixed one. If it is more than 1, then it is a high anion gap acidosis. Suppose you say diabetic ketoacidosis. If you calculate this delta, it will be more than 1. So usually you get a high anion gap acidosis and plus maybe metabolic alkalosis, some amount. So these are the various things which you can sort of read first after knowing fairly well with the compensation, then go to these little bigger things all in one day. Usually I don't teach like that. I usually teach only the first portion. All this is taught in the next class. Okay. So what happens now? Many times you all know what is called the Hamburg phenomenon, right? The hamburger. Whenever there is a too much of, when you have when sodium, the bicarbonate is going, so instead of bicarbonate, chloride enters the cell. So the chloride, though it is, this anion, it has got more acidic component. So bicarbonate is gone out. So you will be getting more chloride. Intracellular chloride becomes more. So this is called a hyperchloremic or non-gap acidosis. So this also occurs. Suppose you given somebody, you went on giving only normal saline, then it can cause this hyperchloremic. Sometimes it can cause in other areas also. So if you have got your urinary anion, what I was telling you, if it is positive, it's a negative, then it is usually extrarenal causes of acidosis. And if it is positive, then it is the renal cause of acidosis is there. So these are the usual things which you try to analyze this. Okay, next.
Can you hear me?
No, it does not. Yeah, so I'll just tell you here. Another case. Yeah, I've got still 10 more minutes. A 25-year-old patient came with a shortness of breath, upper respiratory symptoms, cough, fever, progressive dyspnea for 3 days. Okay. She was a little distressed, respiratory.